Hello and welcome to our channel.
Let's walk through a few important conditions of the salivary glands and nearby structures, step by step, in a calm and clear way. We'll start with sialolithiasis, which simply means the formation of a salivary stone. A sialolith is a small, hardened, calcified structure, very similar in concept to a kidney stone. Instead of forming in the kidney, it forms inside the duct system of a salivary gland, which is the system of tiny tubes that carry saliva from the gland into the mouth. When this stone blocks the duct, saliva cannot flow normally. The most common location for salivary stones is the submandibular gland, accounting for about 80% of cases. This happens for several reasons. The saliva produced by this gland is thicker and more mucus-like. It contains a higher concentration of calcium, and most importantly, the saliva must travel uphill against gravity to reach the mouth. All of these factors make stone formation more likely. Les commonly, stone formen radiographic glands. When minor glands are involved, the upper lip is affected more often than the buccal mucosa, which is the inner lining of the cheek. Sialolithiasis can occur at any age, but it is seen most frequently in young and middle-aged adults. In most cases, there is also moltstone be present. The clinical presentation has a very classic and important feature: pain and swelling that occur during mealtime. Here's why this happens. When you eat, your body naturally increases saliva production to help with chewing and digestion. If a stone is blocking the duct, the saliva cannot exit properly. This causes pressure to build up behind the blockage, leading to pain and swelling in the affected gland. Once the meal is over and saliva production decreases, the swelling often subsides. If the stone is located close to the opening of the duct, a hard mass may be felt during examination. The overlying tissues usually look normal, and there is no ulceration, which helps distinguish this condition from other oral lesions. On radiographs, most submandibular stones appear radiopaque, meaning they show up as white or light areas on X-rays because they are calcified. The best imaging view is an occlusal radiograph, which provides a clear view of the floor of the mouth. Stones in minor salivary glands, such as those in the upper lip, are best seen using soft tissue radiographs. The exact cause of salivary stones is not fully understood, but they are believed to form around a small core called a nidus. This nidus can be mucus, bacteria, shed epithelial cells, or tiny foreign particles. Over time, calcium salts deposit around this core and gradually form a stone. Recurrence after treatment is uncommon. Management depends on the size of the stone. Small stones can often be treated conservatively with good hydration, moist heat, gland massage, and sialagogues such as lemon drops, which stimulate saliva flow and may help flush the stone out. Larger stones usually require surgical removal. And stones in minor salivary glands are treated by excising both the stone and the affected gland. Now, let's move on to salivary gland neoplasms, which are tumors arising from salivary gland tissue. The most common benign salivary gland tumor is called pleomorphic adenoma. The word pleomorphic means many forms, referring to the varied appearance of the tumor under the microscope. Among the major salivary glands, the parotid gland is the most common site overall. For minor salivary glands inside the mouth, the most frequent location is the posterior lateral palate, followed by the upper lip and the buccal mucosa. A very useful clinical rule helps narrow the diagnosis. A lower lip swelling usually suggests a mucocele, which is a mucus-filled lesion. An upper lip swelling, on the other hand, should raise suspicion for a salivary gland neoplasm, especially pleomorphic adenoma. These tumors most commonly occur between 30 and 60 years of age. Benign tumors typically grow slowly, are painless, and feel firm or rubbery to touch. Malignant tumors tend to grow faster, may cause pain, and feel harder and more aggressive. In the parotid gland, tumors usually present as a painless swelling that may grow quite large over time. Early on, the mass is movable, but as it enlarges, it becomes less mobile. Facial nerve weakness or paralysis is a major red flag and strongly suggests malignancy. Inside the mouth, these tumors often appear as dome-shaped swellings. Smaller lesions are smooth, while larger ones may appear lobulated. Tumors on the palate feel firm and fixed because the palatal mucosa is tightly attached to the underlying bone. Features that suggest malignancy include rapid growth, pain, ulceration, facial nerve involvement, and bone invasion. Management usually begins with a biopsy, particularly for palatal lesions. Definitive treatment is surgical excision. Malignant tumors may require surgery combined with radiotherapy. Recurrence can occur if the lesion is not completely removed. Finally, let's discuss the Nasopalatine duct cyst, also known as the incisive canal cyst. This is a developmental, non-odontogenic cyst, meaning it does not arise from teeth. Instead, it forms from remnants of the embryologic Nasopalatine duct, a structure present during early development. It is located in the anterior midline of the palate, within the incisive canal. It most commonly affects adults in their 4th to 6th decades and shows a male predilection. Clinically, it presents as a soft, fluctuant swelling of the anterior palate. The color usually matches the surrounding mucosa, and the lesion may be completely asymptomatic. On radiographs, it appears as a well-defined radiolucency, which can be round, pear-shaped, or heart-shaped. The heart shape occurs because of the nasal spine superimposing over the lesion. It may cause divergence of the roots of the central incisors, but root resorption is uncommon. Treatment is surgical enucleation through excisional biopsy. Very large cysts may require marsupialization, and recurrence is rare. So remember these key diagnostic clues. Pain and swelling during meals point toward sialolithiasis. An upper lip mass suggests pleomorphic adenoma. A lower lip mass suggests mucocele. A midline anterior palatal radiolucency suggests a Nasopalatine duct cyst. Once these patterns become familiar, diagnosis becomes clearer, more logical, and much less intimidating.
Thank you for watching. Please don't forget to subscribe and like the video for more.